I'm going to get started just to make sure that we stay on time. ECMO is not exactly a small topic, and to get it all into 20 minutes is extremely tough. And we've got kids kind of a back-to-back-to-back sessions here, so we'll get started. I'm Jason Theiling. I appreciate you being here. I know it's tough on the last day, especially with the excitement of Sono Wars going on beside. I don't have any awesome costumes. This is just kind of me and what I wear on a regular basis. So had I known, I would have brought my inflatable T-Rex or something like that to fit in with the ultrasound crew. We're going to talk a little bit about ECMO, specifically ECMO during active transport. I have no financial disclosures, but I did want to make sure that everybody was aware. We're going to be talking about people being on pump kind of during transport and then potentially for days or weeks afterwards. And that is, at this time, not an FDA approved. It's an off-label use of ECMO pumps. I talk about the pump that we use, which is the McKay CardioHelp. It currently is approved for 6 hours of continuous on-pump time. So just in full disclosure, I want to make sure that people knew that we were talking about an off-label use. It's something that everybody does. It's not an uncommon thing, but just so that people knew that we were talking about something. It's not experimental, but technically off-label. We're going to talk a little bit about ECMO and how it kind of showed up on the radars of emergency medicine, a little bit of its past. We're going to spend the bulk of our time this morning talking about the logistics that go into transporting a patient actively receiving ECMO. And then I always like to we do past, kind of present, and then I'd like to do the future. We'll look at kind of what the future state of ECMO and transport and kind of the acute phase looks like. All right, so I know that how many of you guys have ECMO programs where you're from? How many deploy in the ED? Yeah, right, so that kind of tends to be the way. It's like, yeah, well, I mean, if we really wanted it, right? So just to make sure, like SAEM, there are people that probably do ECMO multiple times a day. There are people that transport. There are other organizations and agencies out there. But just so that everybody kind of has a basic understanding of what ECMO is, let's do just a quick primer. Hidden in there somewhere is a very ill person. You can kind of see a little toesy sitting up right there. And this is kind of when I first started thinking about ECMO and hearing that we were transporting it with our teams. Like, this is kind of what I thought. I'm like, how in the world are you going to get all of that stuff, right, into a little bitty box with wings on it or rotors on it? So to kind of simplify a lot of that type of stuff, basically ECMO, you take blood from the body, you run it through an oxygenator, a pump, and then warm it, then put it back into the body. Pretty easy. It's kind of like dialysis except for the lungs, right? There's two types of ECMO generally that we talk about. The first is VA ECMO, where you pull from the venous side, put it through the circuit, and then return it back to the higher pressure arterial side. Because it is entering the body at the higher pressure, you do actually get a little bit of cardiac support. So if you believe that the primary etiology of the arrest is cardiac, VA ECMO is usually the modality that we go with. Conversely, VV ECMO, you pull from the venous side, return to the low pressure venous side. You get no cardiac support. It's primarily a respiratory mode. Some people will call it respiratory ECMO or medical ECMO as opposed to cardiac ECMO. So pretty simple, dialysis for the lungs. We oxygenate outside the body. All right, let's talk a little bit about how this kind of even showed up on the radar of emergency medicine, because this is historically something that kind of gets deployed in ICUs. And how in the world are we sitting here talking about it at SAEM? Well, this is data from the ELSO, the Extracorporeal Life Support Organization, big international organization that kind of tracks ECMO activity throughout the world. And starting all the way back here at 1990. What you'll notice is it's kind of nice and flat. 1990, 92, 96, 98. And then all of a sudden in 2009, there's this like kick up, right? That's the base of our hill. And that was because of H1N1, right? We all of a sudden started saying, well, maybe there's a role for ECMO in things other than what we were currently doing. At the time, and I recognize that this is, there's a lot of information up here. This is kind of like one of those magic eyes where it's better to kind of be back, because I don't want you to necessarily focus on any individual line. I just want you to kind of see some trends, and I'm going to point some stuff out. This big white area at the bottom, all these white bars, are neonatal pulmonary ECMO runs. Okay? So all of a sudden in 2009, this red bar that kind of is coming down through here that now is a lot bigger, look at what happens. Boom. That's adult pulmonary ECMO runs. And that's where we started seeing the use of ECMO for H1N1 and ARDS. Surprise, surprise, once we kind of get good at something, we're like, well, what else can we do? Can we use it for cardiac? Again, another bump 2 or 3 years later for cardiac ECMO in adults. And most recently, the trend that you're kind of seeing all the way up there at the top in orange is something called ECPR. That's the use of ECMO kind of as a last-ditch modality in cardiac arrest, or CPR, right? And survivability trends, our most recent survivability, tends to suggest the more experience we have with it, the better we are. So neonatal pulm survivability, 73%. That's astronomical, right? Adult, kind of, again, as we talked about those things, the different uses, adult pulm, the thing that we have most experience with, 57%. Survivability, cardiac at 40, and then ECPR at 28. So about 50, 56, 57% of all those who are put on pump have a survivability to discharge. But 28% for ECPR, that's pretty astonishing, right? Like, and if you think about it, you're like, well, I know that the AHA says of all comers, all cardiac arrest, there's a survivability of about 10%. Why aren't we just putting everybody on pump, right? Like, you've almost tripled your survivability just by simply deploying ECMO, right? Well, hold on. That's a little bit different because you're comparing literally apples to oranges. All right, not literally, figuratively apples to oranges, and I'll tell you why. 10% is survivability of every single person, regardless of age, previous medical history, and interventions for cardiac arrest. When we start to talk about ECMO, you kind of have to be like the right person. You have to, there's a couple of different guidelines. Get your phones out. Okay, wait 10 minutes so that I finish, then get your phones out and put in your favorite academic center, ECMO Guidelines. Something will pop up, right? I know they're out there from Penn and Utah, Sharp out in California does. There's a ton of them out there, but they all kind of say the same thing. They have a block of what they want to do, which includes some inclusion. That one's pretty easy. And then there's a lot of contraindications down below. These are the ELSO kind of general guidelines. Again, most of the criteria that you guys are going to see out there look very similar. So indications, an acute, highly deadly process. Well, we see that all the time. That one's usually pretty easy. Because the survivability is somewhere in the 50% range, the ELSO says, well, we should probably look at something that you anticipate an 80% or more mortality, right? So, but that's a lot of our patients. This is where we start to find that people fall out for being appropriate for being put on pump, and it's the contraindications. Again, big international organization, they're going to put the word relative up front because they don't want to draw a hard line in the sand and say, well, you shouldn't consider this in anybody, but. So most contraindications are relative, first of which is that they have a condition that is incompatible with normal life if the patient recovers. That's hard to make that decision immediately in the acute setting sometimes. All right, well, they have a pre-existing condition. Now, again, these are big academic centers that are typically doing this. Half of the patients that come in, even with a sprained ankle, have a serious pre-existing condition in my shop, right? I call it the comma Duke. It's like, I'm here for my ankle pain, comma Duke. I have a lung transplant. I have 3 types of cancer. I'm on CAR T therapy, right? So a large chunk of our patients would fall out there. Age and size, so the elderly and the morbidly obese are not generally considered great candidates to survive ECMO. It's extremely tough on the body and is used as a contraindication. And then finally, futility. If in your assessment you say, you know what, we can get you on pump, but you're not a transplant candidate, even if we can kind of nurse your heart through this or your lungs through this, at the end of the day, you're not a candidate for kind of any other additional therapy. You kind of have built a bridge, as they say, to nowhere. So once you kind of push the patients through this mesh, surprisingly, the number goes way, way down. But if you're in a situation and you're at a hospital where you do have a patient that does pass all of this, right, and you are at one of these places, ECMO is certainly a possibility, right? Or historically, that's been the thought, right? This is a list or kind of a map of where all our ECMO centers are in the U.S. I'm sure that there are some that are not registered that are doing this that don't show up here. But that's great, because if you work at one of those places, you have all those people, right? You either have an ED attending, or if you're in ICU, you have the ICU attending, a fellow, you've got residents galore, you've got a perfusionist, you've got CT surgeons that are doing cannulation, and Lord knows you got spectators, right? So that's great if you're here and you're at one of those centers. But what if you're there? That is not an ECMO center, right? Historically, even if you had a patient that would pass all of the criteria to be a candidate for ECMO, your options were pretty bleak. You either continue conventional therapy, and you go down this, and because we're talking about a disease process that potentially has an 80% mortality, the patient probably dies. Or you say, okay, I'm here, I think the patient can probably be an ECMO candidate, I'm going to try to package them up in a quasi-stable state and transport them to a larger center and hope that they don't also die, right? But all of a sudden, when we start talking about not just the use of ECMO, but the ability to actively transport somebody who's receiving ECMO, well, the decisions get a lot better, right? The decision now starts to become, well, do I want to do a primary ECMO transport or what they call a secondary ECMO transport? All right, I know they need to get on pump. I just got to figure out how I'm going to get them transported from here to there. So we'll talk a little bit about the logistics. Primary transports are where the referral center, the ECMO center, sends the cavalry. Everybody comes, right? You have not only the transport team with the nurses, but you also have perfusionists. Typically, they bring a surgeon or two. They do everything. It's kind of a Ronco, set it and forget it. They show up. They do everything. Put the patient on pump, put them on the stretcher, put them in the vehicle, and bring them back to the larger ECMO center. Secondary transports are for those hospitals that, well, we have the capability. We do bypass. We have a perfusionist that is on call. I can get the patient on pump, but we have no way of actually maintaining them throughout their course for multiple hours, much less days. But we can get the patient on pump, and if you send the transport team, we'll be able to transport the patient. Sometimes in these, it used to be every single transport, the surgeons went with you, right? You had the perfusionist, you had a surgeon or two, you had your entire transport team. And now actually we're getting pretty good at this, where we kind of have our transport team and the perfusionist. And as long as everything is stable as you can get on ECMO, you don't actually need the surgeon there. And certainly if you're flying, they're sitting up with the pilot, and they're completely worthless to help you in the back, right? So these secondary transports are becoming kind of more of an option as people have the ability to at least get patients on pump at their primary institutions. But we are talking about kind of ECMO and what are the things that you need to do if you're going to do either one of these primary or secondary ECMOs. Well, you need ECMO stuff. You need pump, you need the membrane oxygenator, you need the warmer, all of your medical gases, right? Point of care testing. Our perfusionists like to get a point of care gas right before we move over to our stretcher, and then every hour, hour and a half while we're in the middle of transport to make sure that they don't need to make any adjustments. And then backup is key. Any of you who've looked at certainly the cardio help, there's some type of mechanical backup. It is a machine, so it will fail at some point. And there are these stories, if you've ever talked to some of the transport crews, I've gone to a couple of conferences and you talk about, yep, you know, helicopter landed and there's Bob just cranking the ECMO machine, walking down the helipad, and everybody else panics up. He's like, I've been doing this for 30 minutes. This is nothing new to me. You also got to have just your regular transport equipment, right? So you need to make sure probably you're going to have a ventilator. Even if you're resting the lungs, you still need to ventilate the lungs. All of your hoses, supply lines, medication pumps, and this is one that actually has kind of become a bigger deal, because as pumps start to change, your crew feels comfortable with what they deal with on a daily basis. And even if you're going to a sister hospital, we're finding that even some of our hospitals in our own system use a different set of pumps, and our nurses or medics will get to the side and say, well, this isn't the pump that we use. That's not the time that you want to be getting out the instruction manual to find out how do I make the pump do what I want it to do. Ironically, we've actually had a number of VV ECMOs that are on intra-aortic balloon pumps or Impellas, which seems backwards to me, and everybody is like, why are they not on VA? Oh, no, this will better. Okay, fine, we'll do that. So we'll manage the Impella and the balloon pump as well as the ECMO in transport something that we do on a regular basis without the ECMO, so not a problem. We're not talking about going to CAT scan and back, right? I mean, we are going across the state, up and down the interstate. You got to make sure that you've got equipment security. Straps galore, harnesses, brackets, right? We have to put special brackets into the floor of the truck or the helicopter so that you can strap things down. Specialty racks. In fact, talking to a lot of agencies, a lot of them actually have their clinical engineering build them a special ECMO rack so that they can have everything right there kind of in front of them. It bolts onto their stretcher. Is kind of made to fit within the cabin of their helicopters and is specifically made for them and for the use of ECMO. Obviously, supplies, you have to make sure that everything that you might need, you take with you. Don't anticipate that the outside hospital will have everything that you need. One of the things that we do as a common practice is ask that every drip that the patient is currently on or might be on, because you know how that call goes, oh yeah, no, they're not on any pressors, go ahead and hang the levofed, right? Anything that they're on currently or might be on, get it to the bedside, don't spike it. When our team gets there, they spike it, they put it on our tubing, they put it on our pumps, and then you do the switch over at that point. You're not trying to take something off of one pump and then take it over to your pump on the same line. Just start from afresh and make sure that you have medications. Redundancy, again, is key. You don't want to kind of get halfway through the transport and find out, oh, well, we actually need another bag of whatever. So we always make sure that there's a little bit of redundancy in that. This is a big surgical procedure, right? You're putting a garden hose somewhere in somebody's leg. There's probably going to be some bleeding. We bring 4 packs of reds, 1 of plasma, and 1 of platelets. This is very important. This blood is not for hemorrhagic shock because of decannulation. If they decannulate, that is an emergency. You land, and you get the surgeon out, and you recannulate. Failure to recannulate, this blood isn't going to fix it, and the outcomes tend to be poor. Biggest thing, process. You have to have a plan. This is not something that at 2 o'clock in the morning on a Sunday, you say, y'all busy? Let's go see if we can find us an ECMO to transport, right? This is planned out months in advance. Part of our plan is that our team actually is on the phone call. This is Matt Adams and Jamie Eastman listening to a phone call that's coming in from a referring hospital. On that is the hospital, the intensivist or the ED physician at the outside hospital, the nursing so that they can get a good nursing report, our perfusionist, our surgeons, our intensivists, everybody who's going to come in contact with that patient in the next 20 to 30 minutes or next few hours is on the phone call, so we're all getting the same information. We learned that the hard way by having these separate phone calls, and then half the people got, oh, well, yeah, they are on pressors. Oh, no, they're not. Oh, this is their last gas. No, we just got a new one. Just get everybody on the same page and make sure that you're getting the same information. Down here, this is Kevin Muma. He's our manager. Checklist, checklist, checklist. This is not something that you say, oh, I forgot my wallet back at home. I'll just run by and pick that up. You don't want to rely on your memory to make sure that you have everything you need. So we have entire checklists. Yep, check, 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 just like you do with aviation. One of our guys actually made an ECMO bag that has everything that we need. You just grab the ECMO bag. I think they call it the ECMO bag. It's written right there on the side. And that's everything that you need outside of blood and medications to do a transport. Practice, 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 right? You can have a plan. It can look good on paper, and the first time you go to enact it, something is going to be different. We have monthly ECMO conferences with our perfusionists and CT surgeons and intensivists. We also do monthly SIMs, and then multiple times a year, we actually get in our truck in our ambulance bay, drive all the way around to a random spot on campus, which is set up as an ICU. Sometimes it's a classroom, sometimes it's a meeting room. They actually go through the steps of, here's how we cannulate. This is what we need. I have this. Wait a minute, no, we didn't bring that. Okay, put that down on the list. We need to make sure that we have that for this specific scenario. Then we load them back in the ambulance or potentially take them upstairs, fire up the helicopter. Yep, load them in, load them out, and actually walk through the entire process. Continual quality improvement and quality assurance is key for this. Again, you don't want to be finding out in the middle of an actual transport that you need something that you don't have, or a situation arose that you were not expecting, which will happen. Obviously, if you're transporting patients, you need things to transport them in, right? So trucks are great. They're up to about 250 miles. They're spacious, right? This is what we do on a regular basis. This thing is massive. It's probably bigger than my house. They're generally quiet. There's no weight restrictions. Even with the most lead-footed medic, though, they're still pretty slow. Airplanes are faster, right? Those are great. More than 400 miles. We've done international, picking people up kind of in the islands. We've done them kind of from coast to coast. They're relatively spacious. They're not quite as big as our critical care trucks, but they're pretty spacious. They're reasonably quiet. You've got that low hum in the background, but they're not bad. There's not a lot of weight restrictions. They're fast. The problem with this is that oftentimes you're having to contract with a company. Very few agencies actually have their own fixed wing. And the demand is becoming higher for fixed wings, and so you may say, yep, we're going to go run this ECMO, and you find out that no, it's going to go pick up an organ somewhere, and you've got a delay by 4 or 6 hours, which might be okay if they're stable in the ICU, but certainly if you're talking about potentially picking up from an ED or something, those hours can make a big difference. Our rotor wing. 200 to 400 miles, that'll get most of where you need. If you remember where all those centers were on the map, most of them are within 200 to 400 miles. You do have some space limitations. Anybody who's tried to do a ride-along or a transport in the back of one of these knows that you're very tight if you start kind of adding in a perfusionist, which needs to be there, plus or minus a surgeon. Obviously, weight restrictions start to come in, and it does become a little bit tight. They are fast, almost as fast as an airplane. And most importantly, for the most part, they're within your fleet. This is something that your crew uses on a daily basis. They know every nick and mark, every dent and scratch. They know and love their helicopters. So it's familiar. Again, this is an unfamiliar thing that most agencies are doing, transporting somebody on pump. So as much familiarity as you can build in is nice. One of the biggest things that I found is that you have to have institutional support. There are a couple of agencies that are trying to do these third parties where they pick up from this hospital and they take to that hospital. They don't ever come back to their home base. They really are just kind of doing it almost as a contract type of thing. That is extremely tough. Again, this is not something that is your run-of-the-mill transport, and having the understanding and the familiarity with your team, the hospital, knowing who the person is. You know, conceivably, you're going to one hospital and picking up a perfusionist that you've never met. You don't know what their tendencies are. You don't know how they're going to handle being in the back of a helicopter, et cetera. So I tend to find that having an ECMO-capable center and good hospital support, these tend not to be cheap. So recognizing that you're going to sink a lot of money to a program like this, ultimately, hopefully for the greater good, but that's also important for everybody to kind of know up front as well. So that's kind of where we are. Where are we going, right? So we kind of, you know, a few years ago, like the idea of literally transporting somebody on pump was outrageous. Nobody would have even thought of it, right? And right now, well, these are the people that we know are actively either talking about it or writing about it or publishing about it, but we don't really have a clue how many agencies actually are. As I kind of talk word of mouth, you know, word on the street type of thing, we kind of feel like a lot of these companies and agencies are transporting, even if it's the one-off, two-off. Yeah, we did 5 last year type of thing. But conceivably in the future, this will be transporting somebody just like transporting someone on a ventilator, right? Think about it. A couple decades ago, the idea of taking a ventilator, right, and then actually moving it, first of all, to CAT scan, or much less to another institution, was something that was absurd. And now we've got these little laptop ventilators, and it's not a problem. So conceivably, this will just be a regular run-of-the-mill, this is what we do on a Tuesday type of thing. We know in Europe, they actually are deploying ECMO, well, right over there, right? You know, you can, again, get the Google machine out and put in ECMO in the Louvre, and you've got these famous pictures of people being cannulated kind of in the middle of downtown. I'm a big Land Rover guy. There's this LR4 that's got kind of a perfusionist and pump, and they kind of run to the actual site and cannulate there. So conceivably, this is probably coming from Europe to America, and the idea of cannulating outside of the hospital very well might be a real possibility. Additionally, we've talked a lot about oxygenation, but there is an idea of, well, maybe we can use this to scrub CO2. That COPDer that kind of is a little nodding, you definitely don't want to intubate them, but even positive pressure ventilation is going to be a little bit tough because of their mental status. Maybe we put them on pump, run it low flow, scrub the CO2, do that for hours to a day, and then decannulate. You don't have to worry about the aspiration, all of those risks. You certainly have a risk with cannulation on ECMO, but there's a possibility of that, again, is being done in Europe and is heading, I think, to an ECMO center near you. So I appreciate your attention here. I know that this was kind of a fast tour through ECMO and the transport, but the takeaways: ECMO, it's a thing. It is also a thing that happens in trucks and helicopters, right? But to do so, you probably need to have more than just your crew's support. You need your entire institution and backing of other people. And that in the future, ECMO really might be coming to a coffee shop corner near you, right? I always like to finish with this. On September 8th of 2017, Life Flight 3, which was our Smithfield helicopter, experienced a crash while transporting a patient. All 4 on board were lost. Our pilot, Jeff Burke, Chris Harrison, critical care nurse, Crystal Solinger, critical care nurse, and our patient, Mary Bartlett, who was a nurse in and of herself, all died in that transport. So I like to thank certainly our crew for all of the hard work that they did to help set up our program so that I can stand up here and talk about it and talk about them, and thank them for giving kind of the ultimate sacrifice in the pursuit of advancing medicine and healing the fellow human. I'm Jason Theiling. This is my email down below. We've got another presentation coming up immediately, so I'm happy to take questions, but maybe we'll do it outside. Thank you very much.